The following podcast is part of a certified educational activity titled Achieving Excellence in Gastric and Gastroesophageal Junction Cancer Care, Multidisciplinary Guidance on Immunotherapy Platforms in Resectable Disease. Access the entire activity and complete the post-test at peerview.com/GUA860. Downloadable slides and practice aids are also available.
Hello and welcome to Achieving Excellence in Gastric and Gastroesophageal Junction Adenocarcinoma Care, where we will be discussing immunotherapy platforms in resectable disease. My name is Dr. Yelena Janjigian. I'm the Chief Attending in GI Oncology at Memorial Sloan Kettering Cancer Center, and I'm joined by my colleague, Dr. Samuel Citron. Thank you, Sam, for joining.
Thanks so much, Yelena. It's a pleasure to be here.
The educational goals for today's seminar is to augment your knowledge of emerging clinical evidence supporting the integration of immunotherapy platforms for resectable gastric and gastroesophageal junction adenocarcinoma. Equip your strategies to construct evidence-based treatment plans with immunotherapy regimens in surgical setting, and provide guidance on addressing safety, dosing, and treatment delivery considerations for immunotherapy in early-stage gastric and gastroesophageal junction adenocarcinoma. Progress with immunotherapy in the surgical setting and dissecting rapidly emerging evidence of neoadjuvant, adjuvant, and perioperative strategies is the goal of this masterclass in resectable gastric and gastroesophageal junction adenocarcinoma. We will address the unmet needs and the current standard of care in resectable gastric and gastroesophageal adenocarcinoma, and Dr. Citron will begin by focusing on these topics now.
Yeah, so we'll start by really setting the stage of what is really a pressing global health issue. More than 1.2 million people die each year worldwide from either gastric or esophageal cancer, and that is expected to rise over the coming years as the estimated number of deaths from gastric cancer expect to increase over 700,000 and esophageal cancer reaching almost 500,000 just over the last 3 years. In particular, we're seeing this incidence increase among younger patients as well. And so currently, the standard of care for patients with localized gastroesophageal cancer is with perioperative FLOT chemotherapy. And so this means FLOT neoadjuvantly, followed by surgery, and followed by FLOT adjuvantly. However, even with this standard, as we'll see as we go through the program, a sizable number of patients, nearing 50% of patients, will have recurrence of their disease. What we've learned over the last several years is that the addition of PD-1 inhibitors, in addition to chemotherapy, has improved outcomes and improved survival for patients with stage 4 disease. The addition of PD-1 inhibition in earlier stage resectable disease, though, has not yet been well established until recently. And so why is immunotherapy really important in surgical staging? So until recently, there were really two options for the treatment of resectable gastroesophageal cancer. On the one hand, the FLOT4 trial established that perioperative FLOT chemotherapy, which includes 5-fluorouracil, the L is the leucovorin, oxaliplatin, and docetaxel, 4 cycles neoadjuvantly, followed by surgery, followed by 4 cycles adjuvantly, was superior to the MAGIC regimen of ECF perioperatively. Separately, there was the CROSS regimen, which established concurrent chemoradiotherapy neoadjuvantly was superior to surgery alone. And so until recently, either of these were standard options for patients with stage 2 to 3 disease. Last year at ASCO, and just this past January, published in the New England Journal of Medicine, we saw the results of the phase 3 ESOPEC trial, which was a randomized phase 3 study that randomized patients to receive either of these two regimens. So you can see either perioperative FLOT on the top arm or neoadjuvant CROSS on the bottom arm. Patients receiving the 4 cycles neoadjuvantly, followed by surgery, followed by the adjuvant treatment, or with the CROSS, which is all concurrent chemoradiation treatment up front. And what was presented here is that an improvement in overall survival was established with perioperative FLOT chemotherapy compared to concurrent chemoradiation. Not only was there a significant improvement in median OS and median overall survival, but we also saw the curve separated early and a sustained separation. And 3-year overall survival had a 6% improvement from 52 to 58%. And as we go further out, this improvement was sustained, and that 5-year overall survival was had a near 12% increase from 40 to almost 52%. And when we look at specifically the progression-free survival in the intent to treat population, this gap was even wider, with a near 16% improvement in progression-free survival from 35 to near 52%. And in 5-year, we see the curve really flatten out at about 44% of the perioperative FLOT arm. So while this does establish a really significant improvement with perioperative FLOT and establishes this regimen as the standard of care for resectable gastroesophageal adenocarcinoma, we still see that more than 50% of patients, unfortunately, either have recurrence or progression of their disease or pass away within that 5-year period. And so not only was this progression-free survival observed, but also a recurrence-free survival and distant metastatic recurrence-free survival was improved with perioperative FLOT chemotherapy. And of course, this is 4 months, 2 months neoadjuvantly and 2 months adjuvantly of intensive systemic therapy compared to chemoradiotherapy, which is only 5 to 6 weeks of doublet chemotherapy. And that, in large part, is thought to account for the improvement in survival more broadly. Nevertheless, we know we can do better than this, as we see nearly half of patients develop recurrence of their disease. And so that begs the question of how can we incorporate immune checkpoint inhibition into this. And so you see the two schematics here. On the top, adjuvant therapy, where following surgical resection, immunotherapy is administered. And following resection of the tumor, there are fewer neoantigens present. Whereas if immunotherapy is given neoadjuvantly, there are more neoantigens present. So not only does this lead to a more diverse repertoire of T-cell expansion, but also a deeper T-cell expansion, which would provide a strong rationale for leading to more cures with neoadjuvant immunotherapy.
Great. Excellent primer, Sam. I appreciate that. And so we'll pivot now to emerging evidence on immunotherapy advances in perioperative setting. So as Sam mentioned, the immune microenvironment changes in the tumor are critical to the response to therapy. There's some evidence that as the patient progresses on perioperative therapy, that the level of PD-L1 varies, and particularly perhaps for esophageal cancer, some of the evidence is coming for perioperative chemo-RT data. We also know that in adjuvant setting, immune checkpoint blockade can improve outcomes, particularly when it comes to disease-free survival. And this is data emerging from CheckMate 577 study that combined treatment both for adeno and squamous cancer. In this study, patients with resectable localized cancer who underwent chemoradiation, typically with carboplatin paclitaxel with RT, or the so-called cross regimen, and had surgery and then subsequently had high-risk residual disease with node-positive disease. Patients who received adjuvant nivolumab for up to a year clearly benefited with improvement in disease-free survival and hazard ratio of 0.76 with 2-year disease-free survival of 40% versus 30%. Again, the caveat here is that this is a combination of both adeno and squamous cancers. And as you can see here, quite a few people at beyond 2 years have censoring. So the data continues to mature, but it looks like there's still separation even at 60 months. And when you look at disease-specific metastasis-free survival, again, it looks like for esophageal cancer, there continues to be a benefit. In other words, there's suppression of metastasis and the hazard ratio for that is 0.75. Again, looking at the caveat that these patients got suboptimal systemic chemotherapy with carboplatin paclitaxel, particularly for adenocarcinoma, and that this is a mixture of adeno and squamous histology. But this is reassuring, showing that adjuvant therapy in high-risk disease can at least prevent cancer recurrence. And then the question remained whether or not, will it overall survival be impacted as well? So at this ASCO Congress in 2025, we saw data presented for overall survival from the CheckMate 577 cohort. As you can see here, although there is a separation in the survival curves, the survival and perhaps even at landmark analysis, there appears to be a difference. These curves do start to sort of merge together, and the hazard ratio does cross 1 for all-comer population, with median OS of 51.7 months versus 35.3 months, which is the probably the widest separation of the curve. But the hazard ratio does cross 1, and the p-value is not statistically significant. So in all-comer analysis, adjuvant nivolumab did not improve outcomes even in this sort of high-risk population with adeno and squamous histology mixture. Now, one could look at the subgroup analysis and certainly look at the crossover because metastatic disease is where patients get immunotherapy ubiquitously, and these analyses are also available. And for a subgroup analysis for PD-L1 CPS greater than 1 patients, it appears to be that there is a benefit. So lesson learned from adjuvant therapy. What can we learn about neoadjuvant therapy? In the neoadjuvant setting, as Dr. Citrin mentioned, it makes sense to treat the tumor while the tumor is in place. And data certainly from lung cancer, kidney cancer, melanoma suggests that neoadjuvant setting is where a lot of the benefit begins, with the T-cell expansion of the immune response that can then suppress micrometastasis as the patient is continuing into surgery and recovering from surgery. So the Keynote 585 data is a large phase 3 study that tried to address this question, and this was 804 patients. And the 585 cohort, the interim analysis was based on central review of pathologic complete response, and the pre-specified delta was achieved with p-value of less than 0.01, and this is a delta of 10.9% of pathologic complete response, with path CR of 12.9% in the experimental cohort. And if you look at the flat cohort, the path CR in the flat cohort with pembrolizumab is also similar, 13%. Which, I want you to remember that number when we get to the Matterhorn data. So ultimately what we saw from 585, that cisplatin-based regimen improved tumor complete response, and this was by central confirmation. And then when we get to the endpoints, the Keynote 585 had a co-primary endpoint of event-free survival and overall survival, and this 800 patient cohort was split with alpha across these cohorts. And so although the event-free survival curves appeared to be separating, they're separating relatively late at 12 months. And at the 2-year mark, 58% of patients are event-free, which is defined as either recurrence or progression or death. And although the median event-free survival is trending and improved with 44 months versus 25.3 months, and the hazard ratio is under 1, this p-value threshold for significance was not reached. And it was just barely missed, as you see here, 178 was the threshold, and they were at 0.0198. And if you look at the OS curves, and again, I want you to remember the shape of these OS curves, the hazard ratio is 0.9. And again, at 2 years, although numerically there's appears to be a value difference, these p-values are not statistically significant. The hazard ratio crosses 1 and has not changed practice. And so what we learned from Keynote 585 is that, perhaps, there is some improvement and, some effect in perioperative setting, but this design and this backbone did not meet the pre-specified criteria for clinical and statistical significance. In the follow-up manuscript, they published, the 585 team published the data looking at outcomes by major pathologic response. Because, when Keynote 585 data came out, the field has paused and, really questioned the use of pathologic complete response as a surrogate of event-free survival or overall survival. And here, the dark green curve is the pembrolizumab arm for major pathologic response. So this is including patients with non-complete but durable sort of a reduction in the tumor burden. The hazard ratio appears to be 0.6, and numerically in the number of 79.7 versus 68.4 at 3 months. For the overall survival, there appears to be a similar numerical trend. Again, sort of reigniting the possibility that we could use potentially major pathologic response in the future as a surrogate, interim analysis. It's certainly not powered for any definitive conclusions. The other interesting point, and again, what we are learning increasingly from these immunotherapy trials, and what we knew is that the median values are sometimes not that revealing. In fact, here, the major pathologic response in the placebo arm for event-free survival, for example, the median was not reached or not available yet. So I think these curves are certainly somewhat reassuring, especially on the heels of the Matterhorn data. But I think for the future design of the studies, using the complete response as an interim analysis will need to be reevaluated carefully, particularly depending on how much alpha you're spending and what you're using with that data, doing with that data. The Matterhorn study certainly was presented as a plenary at ASCO 2025, and this was a truly global study. It included patients from Asia, United States, North and South America, and Europe. And so we looked at 900 patients, actually 948 patients, and patients were randomized 1-to-1 to receive anti-PD-L1 therapy with durvalumab versus FLOT versus placebo. And similarly, patients received neoadjuvant chemoimmunotherapy followed by surgery, followed more chemoimmunotherapy, and then adjuvant durvalumab. So it was pre and post chemoimmunotherapy. So what we saw also is that the treatment delivery, even for this global cohort of patients, 19% of patients were enrolled in Asia, 30% were GE junction tumors, and including distal esophageal tumors. And despite that, these patients were able to complete most cycles of perioperative FLOT, which was great. The R0 resection rate was not compromised, exactly the same, 92%, which is quite good for a modern study that included GE junction distal esophageal tumors. And more than half of the patients, 52% of patients, were able to complete all adjuvant cycles of durvalumab and placebo, and also all 77% received adjuvant chemotherapy, which is quite good. We also saw that PD-L1 overexpression was high in most of these patients. 90% of tumors were PD-L1 positive. And as I mentioned, this was a truly global cohort spanning from age 26 to 84-year-old getting FLOT therapy. And event-free survival was the curve separated early and sustained separation of the curves at two different time points, 18 months and 24 months, as a landmark analysis. At 24 months, 67 versus 59% of patients were event-free. And really, Matterhorn supports the global adoption of perioperative durvalumab with FLOT as the new standard for patients with localized gastric and gastroesophageal cancer. Hazard ratio is 0.71, and the p-value is statistically significant. We saw consistent benefit across the subgroups, including patients greater than 65, including patients in Asia, and including patients with gastroesophageal junction adenocarcinoma. And the overall survival curves, unlike the earlier curves I showed you, do separate, and there's a separation at 12 months, and it's a sustained separation. But this data, the alpha was not allocated for OS, so we're still going to do a final analysis in the near future. The hazard ratio so far is 0.78. It's under 1 already, but again, because of alpha allocation, the p-value did not reach statistical significance. The path CR with FLOT is somewhat better. It was 19%, although it's hard to do intertrial comparisons. Again, for educational purposes, as you remember, it was close to 12 or 13% in the 585 data set, and it's 19% here, and a delta of 12% was statistically significant. We also saw in adjuvant setting in patients who had complete resection and were, negative for any cancer, in adjuvant setting, adjuvant chemo and immunotherapy did improve disease-free survival, 75% versus 66% 2-year disease-free survival. Again, meeting all the benchmarks set by the study. Very clear benefit with hazard ratio of 0.7 and p-value with a significance confidence interval of 0.53 to 0.93. As I mentioned, the treatment delivery was quite good, with close to 3/4 of patients finishing all adjuvant FLOT. Historically, from FLOT4 studies and ASOPEC and some of the other studies, especially postoperative esophageal and GE junction patients may have difficulty completing all cytotoxic chemotherapy. In this case, we had excellent treatment delivery. The median number of cycles were pretty much completed for all patients for the median, but the outliers, the 12 cycles were completed in 52% of patients. And the most common side effects are chemotherapy related. The grade 3 for treatment related adverse events were 60% and 59% in durvalumab with FLOT versus placebo with FLOT. So Sam will take you through some mitigation strategies on how to make FLOT more tolerable in your patients. We've been using FLOT for many, many years, so we can give you some tricks of the trade. And adverse events related to durvalumab are quite rare. Certainly, there are some immune-related adverse events, but grade 3 or 4 immune-related adverse events were 7% versus 4%. And there were very few delays to surgery or major adverse events or deaths. The side effects are mostly related to chemotherapy and are commonly diarrhea, nausea, neutropenia, and alopecia. The growth factor support was not prophylactically mandated on this study and was left at the discretion of the treating physician.
So, yeah, really, really exciting and practice-changing data. So let's go through some of the practical aspects of taking care of these patients. Of course, immune checkpoint inhibition has been approved in gastroesophageal cancer now for 4 years, and in other cancer types for even longer than that. But I think it's always helpful, for even myself included, to just go through how we manage this. And so, of course, the list of adverse events is often, in fact, the list can be quite long and longer than what we see with chemotherapy, even though it is on average much better tolerated. And that's just because we can see inflammation in any of the organ systems. You see the most common here being dermatologic and other endocrine hormones, specifically thyroiditis. Now, any sort of adverse events are still in the 30 to 40% range, but it's the severe adverse events that can be more difficult to manage and occur much less frequently. We see when we expect these, it's often not in the beginning of treatment because it takes time to really engage the immune system, and it takes several weeks to months to really see some of these adverse events. But one thing to keep in mind is that even after we discontinue these treatments, they can still cause inflammation in certain organ systems, and you see what's most common here, but it's always something to keep in mind, even if the patient is no longer on therapy. Um, let's delve into the weeds a little bit, and when we think about non-severe, thinking grade 1 and grade 2, these are instances in which we can often consider either continuing or recontinuing after pausing. So for grade 1, very minimal symptoms, and in general, we're able to continue treatment through, of course, some exceptions being if the organ system involved, cardiac, neurologic, hematologic, is more critical. Grade 2, the patient does start to experience some symptoms, and often it's best to briefly hold checkpoint inhibition until symptoms revert back to grade 1 or asymptomatic. Sometimes steroids can be considered, especially as we discussed, if the organ system involved is more critical. But when we think about grade 3 or 4, severe toxicity, even potentially life-threatening, this is when we often consider permanent discontinuation. So grade 3, certainly you're stopping the PD-1 inhibitor, starting high-dose steroids, and then depending on the organ system involved, early infliximab for colitis is really beneficial. And if these patients are able to revert quickly back to being grade 1 or potentially asymptomatic and are able to sustain that after being off of steroids for a period of time, depending on the risk-benefit balance, it's certainly possible to consider, but it needs to be, the balance of what the potential benefit is needs to be thought of very closely because of the significant toxicity. And certainly with grade 4 toxicities from immune-related adverse events, we permanently discontinue the PD-1 inhibition. The only exception is being really endocrinopathies, in which you're able to treat throughout because you're giving hormone supplementation, whether that's Synthroid or hydrocortisone for adrenal insufficiency. And again, here, just another look at this very helpful graph, which you can see in Nature Reviews, just helps to give some guidance as to when to expect each of these. But as you can see, some of them, even the ones that are later, can continue after discontinuation. So the adverse events can persist even after discontinuation of PD-1 or PD-L1 inhibition. And so I think I want to spend the last time we thought it would be really helpful to discuss flood, as I know Dr. Jajigian had mentioned before, because what some of the questions that we often see are, what about patients who they can't tolerate perioperative FLOT chemotherapy? Might chemoradiation be a more appropriate strategy? And what we've seen time and time again is because of the limited systemic therapy that patients receive when they get chemoradiotherapy, it's really just 5 to 6 weeks, a month and a half of doublet compared to several months of triplet. And this is really a systemic disease. That's what's preventing metastasis. That's what's preventing recurrence, that it's really important to be able to give FLOT chemotherapy to essentially all comers who are, if a patient is a surgical candidate, they're a candidate for FLOT chemotherapy, essentially. We saw in the Matterhorn studies, there were patients in their 80s getting FLOT chemotherapy. And this starts with really understanding what are the primary dose limiting toxicities. One is neutropenia. We saw about a fifth of patients in both the FLOT and the FLOT durvalumab arm had neutropenia. And so certainly in my practice, for the first cycle, I'm always giving growth factor, giving Neulasta at the day of disconnect of 5-FU. Now, and then on cycle 2, when they come back and you're checking their white blood cells again, if they happen to have a really profound leukocytosis and a great response, and their bone marrow is not particularly susceptible to intensive FLOT chemotherapy, then may not need it the second cycle. But it's really critical to be able to keep them on that dose dense every 2-week strategy and prevent, not just keep them on the schedule, but also prevent neutropenia, prevent febrile neutropenia. Thinking a lot about GI distress, in particular nausea and vomiting, we saw was also a dose-limiting toxicity. Antiemetic prophylaxis. So certainly really aggressive with the, making sure they have the PRN antiemetics of ondansetron and prochlorperazine right in their pockets, but also adding IV aprepitant on the day of treatment. um, often send them home with olanzapine to take nightly for the first several days to the first week, and then also prophylactic dexamethasone. So they get it intravenously on the day of treatment. But then I also give 4 milligrams on days 2 and 3. So that being the day after when they come back for disconnect, and then the following day in the morning, can do a really good job of preventing nausea for the entirety of the 2-week period, help people who initially presented with these really tight tumors and weren't eating and were losing weight now be able to gain some of that weight back as they go and prepare for surgery after their neoadjuvant therapy. And then lastly, fatigue is certainly really common. And we saw, if you look at with all of the understandable caveats of cross-trial comparison, but Matterhorn compared to Keynote 585 with the triplet compared to the doublet, the improvement in response rates, and even if you see the improvement in survival curves, that we do believe that the triplet is really necessary. And so for a lot of these patients, I would, if fatigue is an issue, considering IV hydration on the day of treatment and the day of disconnect, and also dose modifications um, to help try and keep all components of therapy for as much as possible. And so now Dr. Janjigian and I will discuss, how do we apply this evidence into practice now that it is a new standard of care, and what strategies can be helpful. And so we'll go through one really representative case, just kind of step by step. And maybe I can even just start by going through this, and we'll pick it apart. So um, this is very common to what we see in our clinic every week. 64-year-old gentleman had presented initially with several weeks of progressive dysphagia, wasn't able to eat, felt like food was getting stuck, and now is only really able to drink shakes. Has an endoscopy which shows a partially obstructing gastroesophageal junction mass. The biopsy confirms adenocarcinoma, and the biomarkers come back showing mismatch repair proficient tumor. That's HER2 0, PD-L1 score of 1, really highlighting the importance of needing to test biomarkers. Of course, in the advanced setting, would also really want to know what claudin um, expression is. Undergoes staging with an FDG PET scan, which shows the primary tumor is quite FDG avid, and there are 3 regional lymph nodes, but no evidence of distant disease. So, Elena, let's start with this case, thinking about this at least locally advanced. Is there anything else? Let's say the tumor is continuing into the cardia, or perhaps even the body of the stomach. Anything else you would do? And also, sort of in tandem with that, how do you work with the surgeons in a case of locally advanced GEJ tumors?
Yeah, it's great case, Sam, and of course it's a luxury that all the biomarkers are resulted already. We often see these patients from referring institutions without enough tissue for biomarker testing, and what I would urge, my colleagues, and certainly what we do here, is to not be shy to schedule a follow-up endoscopy, and often that kind of lets the surgeons also get to know the patient, get to know the tumor, the location of the tumor. Because to your point, it's very important to understand from the beginning, is the tumor one of those ugly Leonidas tumors that are extending, starting at the G junction, extending into the stomach, that would need a more extensive surgery. As you know, some of these patients even need more colonic interposition operations and so forth. Or is this a truly G junction tumor that stops in the sewer type 2 perhaps tumor that stops right before the cardia, that you could have a thoracic surgeon do an iverlucid esophagectomy, for example. So typically we see the patient, and based on these features of a clinical assessment, weight loss and so forth, you need to make a decision of what type of workup they need. And typically, an EOS is not that needed in this case, because if a patient is presenting with dysphagia and already the tumor is visible on imaging, a PET scan and a CT scan, it's not a T1B or T1 tumor, and that something more than just surgery needs to be done. But an endoscopy would help you understand all of the features that I mentioned, and also, get more tissue because really the fact that, these tumors could be MSI, MMR deficient is a critical piece that people, need to remember, especially before immunotherapy approval. If and when we get immunotherapy in perioperative setting, it will be less of a issue. But the extent of the tumor, the location of extension in the lymph nodes is critical because, we often say, well, how do we move away from radiation if you can't get an R0 resection? And the answer is that often we can't get an R0 resection because we're taking patients to the OR without knowing all of these factors, and perhaps too soon. And for patients with those high risk features, as I mentioned, bulky extensive tumor, laminitis tumors, tumors that are perhaps not easily resectable, more protracted course of chemoimmunotherapy will be important. How do you decide, Sam, on whether or not to, recommend a laparoscopy?
Yeah, I think I fully agree with everything you said. And I was thinking about the case. I realized, I think we are in somewhat the unique position from the medical oncologist side in that we work with two different surgical subspecialties, and so there's the thoracic surgeons, who deal more with the G junction tumors, certainly the distal esophageal tumors, and then the surgical oncologist, which tends to be more of the distal gastric tumors. But cancer doesn't always respect those boundaries. And so, I know we've shared patients with two different surgeons who, may each need the other's assistance. And so, especially with these gastric tumors, even the G junction ones that really extend as you described, it's a minority, but it's a significant minority that have occult peritoneal disease. And um, unfortunately, those patients are already stage 4 at presentation, and surgery, stopping therapy early and going to surgery is actually going to do harm. So it's, a wise mentor once told me you can't go into battle without an up-to-date map. And so you really need to know what you're up against and go in fully prepared, because if you're underprepared, you're not going to do what's best for the patient. So having that discussion with the surgeon about whether or not a laparoscopy, and also having them set their own eyes on the tumor will help them prepare most for surgery. And I know we've discussed it over and over, but really to put not too fine a point on it, let's say laparoscopy, cytology comes back negative, no gross evidence of peritoneal carcinomatosis, in this patient, what would you recommend? And, even because I'm sure we get the questions a lot, let's call this a PDL1 low, right? One is low. Would that affect at all what you would consider?
I think at least at our institution, everyone agrees now that perioperative chemoimmunotherapy, and starting with chemotherapy in particular, is the way to go, and then radiation does not cure these patients. And you'll review this data with soon. But it's one thing, we understand that this is a systemic illness, and even with patients with gastroesophageal junction tumors, systemic approach with triplet chemotherapy and immunotherapy is really the approach. In addition to radiation, does not improve survival. In fact, it minimizes what we can do systemically. Our surgeons embrace that. I think within DMTs, perhaps in DMTs at other institutions, it will take a bit of time to embrace it. Yeah, but hopefully, with education and understanding of these regimens, the time will come. So laparoscopy, endoscopy, and the Metaport is often done at the same time by our surgeons. And then the decision on what to use, what treatment to use in these patients. I think most 64-year-olds, at least in our practice, even if they're a bit nutritionally compromised, can tolerate 3-drug chemotherapy with FLOT. And certainly DFLOT with durvalumab, FLOT has been well tolerated, at least from our experience. But you have to be cognizant of possibility of adverse events because it is major chemotherapy. And so what we do is really focus on patient education through nursing. I am just one member of the multiple, member team. So nurses, fellows, treatment nurses, and so forth, um, who will educate the patient on how to manage their adverse events and report them. And for the patients who perhaps may be a bit more frail, we have them come back for disconnect and get hydration. And we also, consider dose reductions. Remember, in the Matterhorn study, dose reductions were recommended per the local institutional guidelines. And one thing that we demonstrated with Matterhorn is that globally, uh, doctors and patients have been able to tolerate FLOT and finish it. And so that's great to see. So I typically start with FLOT with perhaps, in some patients, dose reductions, even from the beginning. We often drop the leucovorin bolus, and we often, start with the lower doses of docetaxel. And certainly with durvalumab, this regimen has been well tolerated. It's every, 2 weeks FLOT and once every 4 weeks durvalumab. So the schedule of it really makes it very acceptable for the patients. So I'm curious to see, Sam, what your thoughts were about using prophylactic Neulasta or GCSF or Neupogen in these cases.
Yeah, absolutely. I use it regularly, certainly with the first cycle, as we're seeing how sensitive that patient's bone marrow is to chemotherapy. And as good as we sometimes like to think we are at predicting who's going to tolerate it well or not, we're not as good as we think we are. And I've seen young patients whose white counts will drop precipitously, and older patients even who have gotten treatment for other cancers before, whose bone marrow holds steady, but you don't really know that until cycle 2. And so I always start with Neulasta the day of disconnect. And then if they have their white count goes into the teens, maybe they don't need it for cycle 2 and we'll go again for cycle 3, but it makes sure they're not neutropenic, no reasons for hospitalization if they get an infection, and keeps them on the schedule in a safe way. And we know that FLOT above chemo RT, you're curing more patients. DFLOT above FLOT, you're curing more patients. And if you look at those curves, this is, we talk about prognosis. This is an intense period to go through, but it's curative intent, and appear to be curing about 60-65% of these patients. So let's say, this gentleman, heeds our advice. We get him through the neoadjuvant DFLOT. He goes through surgery, has an RZO resection. The surgical specimen is reviewed by pathology. T2 and 0 has a 75% treatment response and is here to discuss adjuvant therapy. So how do you think about, that they had a response, nodal downstaging? Would you just give up now and say you're done, you're cured, it's out, or what do you think?
Well, I think these patients in particular need to keep going because the impact on micrometastasis is what we're trying to deliver on. And even from other studies where patients who were non-responders pathologically were then randomized to receive dual immune checkpoint blockade versus FLOT. FLOT was important. The dual immune checkpoint blockade was actually by itself without chemo was not helpful and maybe actually detrimental. So we know this disease is continued sensitive to chemotherapy. We know that FLOT in adjuvant setting is safe. The Matterhorn data showed that it didn't impact negatively on recovery or the resection or surgical approach. And certainly we can do it in adjuvant setting. And then for this patient who is PD-L1 positive, it's particularly important. But the rate of PD-L1 negativity is so rare in this tumor that the subgroup analysis was so small that really it's hard to make any definitive conclusions. But the hazard ratio estimate was still in favor of using immunotherapy. And so the community and the experts agree that really we should continue immunotherapy in neoadjuvant and adjuvant period. And I typically resume FLOT when the patient is stopped losing weight and is able to eat. Nutrition is so important for our disease. And some patients lose quite a bit of weight, but if with the weight loss stabilized and is starting to creep up, or at least plateaus, it's a good time to resume. The time to resume treatment was flexible in our study. It can be up to 3 months if you need to wait that long. But I can tell you, most of the time, I see the patients 5 weeks post-op, and then most patients are able to resume therapy 8 weeks post-op. I would typically, again, review carefully my notes and talk to them from how do they tolerate the treatment with the last cycle, and use that as a guide. Certainly, if they were if it was well tolerated, we could use the same doses of the chemotherapy as was used in the last cycle neoadjuvantly. But often, the neoadjuvant treatment is better tolerated. So in adjuvant therapy, often I'm even more generous with dose reductions. And it's not wrong to drop one of the components of it. I think we know that fluoropyrimidine is the most important treatment out of those three. Certainly, platinum is important as well. And docetaxel, if you're able to get it in the patients, that's great. But if not, remember in FLOT study, in the both FLOT 4 and the Matterhorn study, it was any components of FLOT that was delivered was sufficient to show benefit. So I think combination of FLOT, durvalumab, and adjuvant setting is ideally what we would do. And if the patient is intolerant to any components of FLOT, drop that, and eventually continue immunotherapy alone.
Yeah, I mean, the Vestige study is the one you quoted that randomized, and so anything seems to be better than nothing chemotherapy wise if their patient is able to tolerate it. I totally agree about the weight. Weight stability is my metric too, and any ideally within 3 months, but really closer within the 4 to 8 week is the target I tend to work with on patients. And of course, the longer they're getting checkpoint blockade, the more likely that they will develop an adverse event. But we reviewed the adverse events, and the large majority, these are very manageable, and we're able to get them through it. It didn't meaningfully inhibit the amount of or detract from the amount of chemotherapy that these patients were able to receive.
We hope you found this program useful and informative for your practice. Thanks again, Sam, for the lively discussion.
Thanks so much, Yelena, and thank everybody for participating and attending this session.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from AstraZeneca. To access all materials for this activity, visit peerview.com/GUA860.